Is my screen visible again? Am I good?
No, you have to start over.
Okay, great. Thank you for breaking into groups. Are there a few people who want to share what groups discussed and kind of what your general approach is? And then we'll launch into the data that I found.
I guess I can just share with what we talked about. So we just kind of talked about how I think the first question I have is, are they like a heart failure patient who came in with severe volume overload? What's their kidney status? And do I think that giving some fluids is going to be particularly harmful or not, are generally the questions that I ask. And then as far as like fluid responsiveness, I've been doing a lot of like passive leg raises lately if I'm able to see if they have any like lowering of their heart rate. But otherwise, I think in general, I just kind of try a little bit of fluids, and depending on their heart failure status, kind of determines how much fluid I will try.
Anyone else want to share your general approach, and then we'll hop forward. Thanks, Stephanie. Okay. Yeah.
Someone mentioned POCUS in our group of whether or not to use that to make a decision about fluids. And then we went back and forth about the evidence on POCUS.
Great. So we'll talk about it. Yeah, thank you. Those were a lot of the themes reflected in my group as well, as like, will this be particularly harmful? And I think there's another question of like how big a decision is this for this patient, and should we use ultrasound? And I'll be interested to hear people's experience with passive leg raise.
I think just to add a little bit, Lauren, to the which conditions are you most ginger with, I always think of cirrhotics, because even if they're intravascularly volume down, they're going to most likely third space whatever you give them. So it may not be the best way of helping them, unless you like think about giving them albumin with the fluid as well. But it may not be something that you can keep doing.
Right. Great. Thanks, Laura. Good point. Okay, so for the rest of the talk, I'll talk about the formal definition of fluid responsiveness, talk about the physiology. We all know this, but I think it is useful to frame the discussion and to think about explicitly, which I don't do every time I decide whether or not to bolus a patient. I'll go through static measures of fluid responsiveness, which, spoiler, are not very good, and then some of the dynamic measures and the data for those, and then some take-home points and hopefully a bit more discussion. I have no financial disclosures. My bias going into this talk is that I wanted something that was easy to use, slam dunk, practice changing, and that would make my clinical decisions for me. And I did not find that, obviously, but we'll go through the data. So this is the formal definition of fluid responsiveness, and that is an increase in stroke volume of 10 to 15% after a patient receives 500 cc's of crystalloid given pretty quickly over 10 to 15 minutes. This definition comes from Paul Marek in a pretty landmark article in the field published in Annals of Intensive Care in 2011, and seems to be pretty widely accepted in both in later studies and in Life in the Fast Lane blog posts, and pretty extensively. So this is the formal definition. And moving on to the physiology, which won't be a surprise to anyone. But just to say it explicitly, this is what we're trying to achieve when we give fluid for hypotension or tachycardia or whatever condition. So we're trying to give preload. We're hoping that that will increase stroke volume. And then because we know stroke volume times heart rate is cardiac output, we hope will increase cardiac output, which will improve tissue oxygenation and oxygen delivery, and then the patient will be fixed, ideally. Importantly, the question of fluid responsiveness stops after the first half of this quite optimistic series of events. It's just saying, if we increase preload, will we get an increase in cardiac output? Are they on the steep part of their Frank-Starling curve? So here, as we're all familiar with the Frank-Starling curve, with cardiac preload on the x-axis and stroke volume on the y-axis, if we're given a certain central venous pressure and our patient is on this very nice upper curve, we'll get a great response in stroke volume from giving additional preload. But if our patient is on this more unfortunate lower curve and we give a bunch of preload, we don't really get the effect we want, and we probably will get effects that we don't want. But really importantly, and I want to emphasize, and Laura, you just brought this up, that just because you can give fluid doesn't mean you should, even if they're on the steep part of their Frank-Starling curve, even if you'll have some response to fluid, there might be other deleterious effects that you want to consider. And we might be running patients dry for a certain reason if they can tolerate that. So what's wrong with giving fluid? And if people want to just kind of throw in the chat what you worry about, Laura already mentioned the people are going to third space it, and why wouldn't you just give everybody fluid for a bolus? And I see in the chat from Molly that we'll talk about IVC measurements.
One of the problems with fluid is, people can third space it obviously, but it can also end up in the lungs, cause pulmonary edema, and cause sort of worsening respiratory status if you're giving people fluids blindly.
Exactly. So there are a lot of deleterious effects of fluid that we're all familiar with. And when this is formally examined in trials, these harms are identified. And a lot of these are big trials of association, not necessarily randomized clinical trials, although those are coming. So fluid resuscitation in septic shock, it's been noted that a positive fluid balance really all along the course of the spectrum of treatment for septic shock and elevated CVP are associated with increased mortality. Positive fluid balance is also associated with worse mortality in patients with acute renal failure in another critical care study. And interestingly, there are starting to be trials of fluid resuscitation in randomized control trials that are showing deleterious effects. So this Andrews paper in JAMA a few years ago made a big splash in the global health critical care literature. They carried out a big randomized control trial, early goal-directed therapy in sepsis. It was based in Zambia, and they very unexpectedly found increased mortality with their protocol in patients who got the aggressive fluid resuscitation. Probably, as Emily mentioned, because these patients got pulmonary edema and there wasn't a good way to rescue them because they didn't have ventilators. So this is a very specific setting with very different epidemiology from UW. But there are starting to be trials here. I think people are familiar with the Clover trial that was enrolling, I think finished, so maybe we'll see results soon, looking at a way more restrictive approach to resuscitation and wondering whether we can spare people some of the deleterious effects of aggressive fluid resuscitation. In addition, fluid excess has been noted to be a problem in ARDS. It's obviously a problem in abdominal compartment syndrome. It worsens wound healing. It increases ICU length of stay when this is studied formally in association trials. So the goal is to understand where the patient is on the Frank-Starling curve before we actually give the fluid, if it's a patient for whom the fluid is going to be our problem. And interestingly, in meta-analyses, about 50% of patients are formally fluid responsive after initial resuscitation with some variation across studies. But maybe that would be less than I would have expected, given how often we bolus people. So now that we've set up the clinical question, I'd like to address some of the measures that have been analyzed to inform this decision-making around fluid responsiveness, beginning with the most tried and true static measure of patient assessment, physical exam, which hasn't been super well formally studied for fluid responsiveness, but where it has, there have been a few small studies, and its physical exam in isolation is not very good for determining whether someone will be fluid responsive. So the studies are small, but there was one article published in Journal of Critical Care in 2013 where they looked at 24 patients and they had a really thorough physical exam. They looked at the tongue, they looked at hand veins, with the arm in different positions. They looked at cap refill, EJ, not sure why they didn't look at IJ, pulmonary auscultation, abdominal exam, leg exam looking for edema, and skin turgor. But the positive likelihood ratio for an exam consistent with fluid responsiveness and negative likelihood ratio were not only cross one, but were really close to one. So physical exam on its own was not very helpful. And it's a little bit academic because you would never use physical exam by itself without knowing something about the patient. But I think it just goes to demonstrate that there can be a lot of signs of extravascular excess when patients could benefit from fluid or vice versa. So looking at other static measures, so physical exam on its own is not predictive. These are some numbers that we're very familiar with. They've been featured in early goal-directed therapy algorithms, and they are still featured in the surviving sepsis guidelines. They are central venous pressure, mean arterial pressure, urine output, mixed venous sat, and lactate measurements. And interestingly, when there was a lot more protocolized care for sepsis and big trials, people would get potentially a ton of fluid. So you can see in the middle of this protocol for one of the arms of the process study published in NEJM in 2014, if the CVP measurement was under 8, they would potentially end up in this kind of endless loop. And this was after initial resuscitation. So they'd already received like 30 cc's per kilo, and they could end up really getting flooded. And the end result of this trial notably was that this algorithm was not better than standard care. First of all, you didn't need the CVP number used to guide care versus just peripheral blood pressure, didn't affect the outcome. And just the way people had been handling care without an algorithm, the algorithm was no better. So people in both arms ended up getting a bunch of fluid. This was particularly really aggressive. So how good are these static measurement numbers, and should we be using them to guide the assessment of whether a patient is fluid responsive? There's some data for using central venous pressure if you have that value, although it appears to be on its own a modest index at best. So CVP can be directly measured from a central line, or you can estimate it from a formal echo. It's a measure of pressure in the IVC and is roughly equivalent or exactly equivalent, depending where you place your central line, to the pressure in the right atrium. CVP gives a sense of right atrial filling and therefore right heart preload. Normal is 0 to 8 centimeters of water. CVP also gives you a sense for the gradient of organ perfusion because it's the gradient across which, for example, kidneys are perfused, the MAP minus the CVP. And CVP is frequently cited as a measure used to guide fluid resuscitation if in surveys with various providers, but it's not the best index. So looking at data using CVP as a measure for fluid responsiveness, it's somewhat controversial. A large meta-analysis published in 2013 looked at 43 studies, 1,800 patients, and somewhat notably, it was from this Dr. Marek at Eastern Virginia, who almost seems on a rampage against using this value in isolation. And other analyses have been a little bit more forgiving, but do follow the general trend that this study found. So in this meta-analysis, fluid responsiveness was defined as 15% increase in cardiac index after a 500 cc bolus. They mostly use colloid. Now we would mostly use crystalloid, and about a little over half the patients were fluid responsive. But the meta-analysis found that the fluid responder CVP was slightly numerically lower, but not significantly lower than the non-responder CVP. They were quite similar. And the summary area under the curve for whether CVP could discern whether someone would respond was 0.56, so almost no discernment ability. And the conclusion from this meta-analysis was that it's not a good measure for fluid responsiveness. Looking at another giant meta-analysis, this one published in JAMA in 2016, they used a cutoff of CVP, like looking at less than 8 versus greater than or equal to 8, and they found a positive likelihood ratio of about 2.6 to respond to fluids, negative likelihood ratio of 0.5 using that cutoff. So it was a somewhat discerning indicator, but nothing to hang your hat on. It certainly wouldn't be a value that you would want to use in a protocol to decide to keep going in kind of perpetuity. So the reason these static measures are not everything we wish they were is that they tell us where we are, but they can't tell us where we're going. For example, if you have a CVP, let's say this is a CVP of 8. All the patients on this red line have a CVP of 8, but this number can't tell you whether your patient is this patient or this patient, and is not at all discerning. So static measures are not great at telling us whether someone will respond to fluid. They kind of tell you where a patient is in a given moment. And we'll move on to talking about the data for the more dynamic measures, which are quite a bit better. In particular, as some people have alluded to, the passive leg raise. So as going back to this JAMA meta-analysis, which I think was really excellent in identifying likelihood ratios for all of these different techniques. So for a change in cardiac output of 11%, the positive likelihood ratio a patient would respond to fluids is 11. The negative likelihood ratio is 0.13 for a really impressive diagnostic odds ratio of 88. It's even better in mechanically ventilated patients, but this is also useful in patients who are on the floor that you're getting paged about in cross cover. So this is as close to a crystal ball as we're going to get it. So you can use it in patients who are spontaneously breathing. You can use it in patients on low tidal volume ventilation with low lung compliance, with cardiac arrhythmias. That limits a lot of the other studies. And it sounds super simple. You put their legs up in the air, you mobilize about 300 cc's of blood, which serves as a reversible bolus, and you can see hemodynamically what happens. If you like their hemodynamic response to that pseudo bolus, then you can give fluid and keep it going, maintain the effect. If you don't like what you see, you put your legs back down. It's like it never happened. And then you don't bolus and you have an answer to that question effectively. So it's interesting because a couple of people, I haven't seen this done a lot. So I had a question of whether people have actually used this, but it sounds like people have. And Sheila was mentioning in one of the breakout groups. And yeah, what has been people's experience and how have you used it? Because I think that the formal technique for doing it is quite difficult and involves invasive monitoring, but it might be a test that's useful to gather kind of informal data, even if it's not the numbers that were used in clinical trials.
I think that the reason why I haven't used it as much as I wish I had is because being a small woman, you actually have to hold the legs of the patient up for a significant period of time. Is it just 60 seconds? I've heard that it's at least 2 minutes.
Oh, interesting. The JAMA are 60 seconds, which I would struggle to do with some patients' legs are quite heavy.
And didn't the results like dissipate after 90 seconds? Between 30 and 90 seconds, I think, is when you see the peak result, right? And then it kind of diminishes thereafter. Is that correct?
Yeah, you kind of, I'm not sure the exact time intervals, but the effect does dissipate after a bit is my understanding. And you kind of get that rush of the bolus and you want to see what that is when it immediately goes into the more central circulation.
So when I've done it, the nurses actually have done it in the ICU. I think our nurses in the ICU are trained to do this maneuver. And so I usually have them recycle the blood pressure at 30 seconds and then at a minute.
And have you found it to be pretty useful to guide your management?
I mean, yeah, it showed that they're fluid responsive. The tough thing is that when you're giving additional fluids, that's tough, is following up to see if you're going to give more fluids, and then it's not as helpful after the first bolus. And I feel like now we're moving towards early pressors anyways, so.
Those are all very good points. So to perform a passive leg raise, I'll describe in a little more detail. You start with the patient in a semi-recumbent position, pretty normal. All of the patients are in this position nearly most of the time. And then you raise most of their body to about 45 degrees. And where I hear you, this is really hard to do. Most of the beds won't do this 45 degrees is quite steep. The nurse might come running if you try to do this on your own because you look like you're about to drop the patient on the floor. And in the formal studies, the ways that they measured cardiac output and how the way that this test was validated was with some more difficult measurements. So in some of the studies, they used bedside echo, non-invasive, but they identified left ventricular outflow tract velocity time integral, which probably a few of you can do this. Probably Chinonsa can do this. JP, maybe you can do this. My bedside echo skills are not quite up to being confident in that calculation. Sometimes if the anatomy is difficult, I can't even find the left ventricular outflow tract, but that would be a great goal because that would be a really useful measurement. And other options include the calibrated pulse contour. That's a commercial system. It analyzes an A-line tracing, a bioreactance device, which is also expensive, esophageal Doppler, transpulmonary thermodilation, or a PA catheter, and those are all invasive. If you have those, then great, but a lot of patients in whom we're asking this question don't have them. So we have this very useful technique, and the formal way of looking at this technique is out of reach for a lot of patients. We don't want to place a pulmonary catheter in every patient in whom we're giving fluids. So studies have also validated examining the change in pulse pressure variation on an arterial line before and after passive leg raise. It's not going to be as good as transpulmonary thermodilation, which is unsurprising, but it's probably better than just physical exam or CVP. It might be better than just looking at the blood pressure or the change in heart rate. A lot more patients have an A-line than a PA catheter. And you might even be able to, with just taking the blood pressure manually, think about the pulse pressure variation. So to examine the pulse pressure variation after passive leg raise, you would start by measuring the pulse pressure, the difference between the systolic and diastolic. Then you would perform the maneuver and measure the pulse pressure again. The pulse pressure variation is the difference between those two numbers divided by their average times 100. And if it's greater than 10%, the patient's likely to be fluid responsive with a positive likelihood ratio of about 3.6. So not as impressive as if you had the really formal passive leg raise measurements, but probably a lot better than certainly physical exam or just knowing the CVP, which is not a dynamic value. So in summary, it's fairly technically invasive to do in a formal way, and you might need an arterial line, but as people have been practicing, you can also just put their legs in the air and see how the heart rate and peripheral blood pressure change. It's important to know that this wasn't the really validated excellent test, but this is certainly practiced. I ran the parts of this presentation by Dr. Hung, who's the current PulmCrit fellow on pulmonary consult, and he seemed to think that was a reasonable approach, and you're going to use the measurements that you have available. So if you have vital signs, then you'll use vital signs. Great. So other dynamic measures. You can, in a patient who's vented, importantly, and all of this pulse pressure measurement requires normal sinus rhythm, otherwise you have too much beat to beat variation and it won't be accurate. But in a patient who's on a vent with normal sinus rhythm and a relatively normal right heart, you can just use the pulse pressure variation that you see with mechanical ventilation without doing any specific maneuver. So for tidal volumes greater than 7, the cutoff's an 11% change, with a positive likelihood ratio of 5.3, negative 0.19, so quite good. For lower tidal volumes, the cutoff is at 8%. The positive likelihood ratio gets better, the negative likelihood ratio gets worse. So the physiologic idea behind this is that the pulse pressure will vary with different phases of the respiratory cycle, and the exact mechanism kind of varies by what you read and who you ask. Probably it's that a positive pressure breath increases intrathoracic pressure, decreases RV preload, and that happens in a more exaggerated way when there's preload reserve, i.e. fluid responsiveness. When the vent isn't pushing in as much air, the heart is allowed to fill, you get better cardiac output. But there's a delay in the effect of the respiratory cycle because the blood has to cycle through. So it becomes pretty difficult to identify like exactly in the tracing how it's varying with which phase of the respiratory cycle. But the important thing is that you're looking to see whether there's a wider pulse pressure alternating with a narrower pulse pressure, even if you can't quite line it up with the phase of the respiratory cycle. You just want to see if there's that variation. And if the pulse pressure variation is above threshold, then the patient is likely to be fluid responsive. So moving on to the final dynamic measurement I'll discuss in detail, and this came up, I think there's a lot of interest in this because it's fun and we're all learning to do it and ultrasounds are becoming more available. So I'll talk a bit about IVC
Lauren,
variation. Yeah.
Quick question. What was the number for change in pulse pressure that indicated a positive response, just before you move on?
So it was around, so with the passive leg raise, the studies I saw said 10%. With mechanical ventilation, it depended on the tidal volume. So it depended on like how much pressure was in the intrathoracic space. So it was 11% for higher tidal volumes and 8% for lower tidal volumes. And that was the mean across the studies in this meta-analysis.
Great, thank you.
Great. So we'll talk about the IVC variation. So I've heard a lot of different things quoted on rounds, and someone had mentioned in the chat as well that this is validated both in patients who are on a ventilator and patients who are spontaneously breathing. And yeah, so from the meta-analysis data, it's not entirely clear which is better and which is more validated because the confidence intervals are kind of wide, but it's validated in both settings when it's pure mechanical breaths and not. And in general, the positive likelihood ratio for IVC collapsibility is probably around 5, negative LR probably somewhere between 0.3 and 0.7. So to find the IVC, you start with the subxiphoid view with your probe pointed toward the patient's left. You try to find cardiac activity, try to center the right atrium. You slowly rotate the probe counterclockwise until you end up with this beautiful view, or maybe even a better view of the hepatic vein, depending. But you should be able to see the liver, the hepatic vein, and the IVC emptying into the right atrium. You identify the place about 1 to 2 centimeters from the emptying into the right atrium, and you go into M mode in that area. So in summary, you have like your moving hand on the patient's moving abdomen, and you're assessing a moving vessel. So that's probably where the wide confidence intervals come from. And a point that Ryan was making in our big art group was, you know, how good is this with a medicine resident versus a critical care attending versus an echocardiographer? I think are probably different answers, but I didn't see studies that spoke to the assessing different operators. So if the IVC is more collapsible, the patient is more likely to have preload reserve. The magic number is about 40% in the spontaneously breathing patient and 15% in mechanical ventilation when there is some amount of positive pressure in the thoracic cavity at all times. If you are off axis or if you're not perpendicular, then this measure won't be accurate. So spending a lot of time trying to find the view is worthwhile, and I'm sure practice makes better, but it's hard sometimes to be confident in this measurement. So there are a lot of caveats to this measurement in different types of patients. Even after you find the window, even if you're doing a perfect measurement. So it's important to know that IVC might still collapse despite fluid resistance in several different types of patients. If a spontaneously breathing patient takes an overenthusiastic breath or sniff, he'll exaggerate the negative intrathoracic pressure and can make an otherwise distended IVC collapse misleadingly. The IVC will be more likely to collapse in patients with high intra-abdominal pressure, i.e. like half your list at the U and probably the patient that you're most interested in knowing this information in, then this won't be as valid. If you have a vented patient and they trigger a breath, there's like a sudden decrease in intrathoracic pressure when previously had been more positive pressure. And then in patients with really bad venous tone and bad cardiac function, they can be off their Frank-Starling curve even when the IVC pressure is low enough to have a lot of variability. So this isn't the best test in those patients either, but certainly we do use it. Conversely, the IVC might not collapse even if a patient is fluid responsive. If a spontaneously breathing patient takes a particularly wimpy breath without really using their diaphragm, then it might not be enough to get movement. Or in the patient who has really good venous return and really good cardiac function, they might have a really high IVC pressure that's not distending, but they can still take more fluid because their heart is so excellent. I want to briefly mention the End-Expiratory occlusion tests because it seems to perform okay, but it's not as extensively studied or broadly applicable. The idea is that you interrupt mechanical ventilation at end expiration when the intrathoracic pressure is lowest, and that interruption is effectively a preload challenge because it lets the heart fill without having a positive pressure breath. You then either use invasive hemodynamic monitoring or echo of velocity time interval of the LVOT to assess fluid responsiveness, and their cutoff was actually only a 5 to 8% change in cardiac output. But this is super limited. So it's only in patients who are vented, but it's also only in patients who aren't going to try to initiate a breath if you stop ventilation for 15 seconds. So this might start to be a really useful tool, but it's pretty limited, the patients in whom it'll apply to. And it doesn't seem like there have been as much studies on this, and it hasn't made it into the meta-analyses yet. So my conclusions after going through all these data and then also talking with Dr. Hung a bit on this topic is that fluid responsiveness is actually quite difficult to determine after the initial resuscitation. It's important to determine because fluid, like anything else, is a medication with a therapeutic index. It's very easy to fall short or to overshoot, which is probably why we're moving a lot more toward earlier pressors to avoid the deleterious effects of giving too much fluid. Physical exam in isolation is pretty worthless for predicting fluid responsiveness. It just tells you about extravascular excess or even intravascular excess. CVP is somewhat more useful with good clinical context. Passive leg raise is probably the best maneuver we have, but it's important to know that it was validated with invasive or more technical hemodynamic monitoring. Pulse pressure variation is useful if a patient's in sinus rhythm or they're vented. And IVC collapsibility is usable in many circumstances, but also has a lot of caveats. Finally, it's an active area of research. There will be more to come in the next few years, including advances in devices. And it'll be interesting to see how this evolves. I think this is the pendulum swinging toward giving less fluid. And I think some of these techniques will be useful. I'm certainly going to use them more. I think I'm going to be attempting a lot more passive leg raises, but knowing that that wasn't exactly what was studied if I don't have the invasive monitoring. Yeah, so most of my references were listed on the slides. These were the studies I used most heavily. And of course, the details on UpToDate and posts on Life in the Fast Lane were super useful for wrapping my mind around this topic. Yeah, but looks like we're close to time, but I would love to hear kind of people's response to this, what you think of some of these data and whether it changes your practice at all.
One question in the chat too. Do you use the sniff maneuver related to IVC variation? Has this been validated? Feeling like people have seen providers do this.
Yeah, I've seen this a lot, and I've done it. I didn't see anything about validation of the sniff test, and I think it seemed like that would create more negative pressure than the way that this was validated. Because if you're having someone sniff, that's really different from normal tidal breathing. The way I've seen that incorporated and the way I think it can be useful is if there's no collapse with sniff, then the IVC is really distended. So it can kind of tell you about that extreme, but it's not as sensitive. I don't think that was validated. I didn't run into that at all.
Thank you, Lauren. That was great. If there's any questions, we can hang out for a second, but otherwise, everyone have a good afternoon and enjoy your lunch break.